Hello friends, I am Dr. Deepak Garg and today we will talk about injured cervical spine. So let's say we have a patient who is presenting to us in the emergency department and we are called for the patient evaluation. So we should know about some basic concepts before. Let's talk about the epidemiology. So what is the incidence of a blunt trauma to the spine? So it is around 2 to 6%. What is the proportion of all spinal injuries? So it is around 33%, which is 1/3 of the patient will have the spine injuries. Now let's say the patient is having a spine injury, then what proportion of the patients will have unstable injuries? So it is around 43%. So it's a huge number of the patients will have unstable spinal injuries. Now what is the proportion of missed injuries? So it is 0.2%, and consequence of missed injuries is catastrophic neurological deficit and litigation risk is very high, so must not be missed. Now because we cannot miss these injuries, that's why this article or this talk will become relevant. Now what is the risk of prolonged cervical immobilization? Now we are in the emergency department. Now we have to decide whether we have to make the spine immobilize or not. So now if the patient is not conscious and we have to decide about the cervical spine, in that scenario we cannot clinically examine the patient. It is better to keep the patient's cervical spine immobilized with a hard collar. So if we keep the cervical spine immobilized for a very long period of time, then what is the incidence of getting skin ulcers? So it increased 66% additionally with every immobilized day. So we should try to keep the immobilization period as minimum as possible. Patient will have an increased ICU morbidity, patient will have an increased cost, and patient will have a discomfort. So there should be a judicious use of the hard collar in a cervical spine patient. Now what are the clinical protocols to clear the patients of cervical spine injuries? So there are two criteria. One is a NEXUS criteria. So in the NEXUS criteria we look at the midline cervical spine tenderness, neurological deficit, whether the patient is alert or not, intoxication, or the mechanism of injury, whether this is distracting injury or not. So based on these parameters we will clear the patient if from the cervical spine, or we will go for the imaging. But the NEXUS criteria has a poor reproducibility, so clinically we do not prefer using a NEXUS criteria. Then which criteria we use? So usually the used criteria is a Canadian cervical spine rule, CCR. So first of all we should know who can you apply this to. So we can apply this only to the alert patient. If patient is not conscious, we will not be able to apply CCR. Patient should be stable, age should be more than 16 years, and patient is a case of suspected cervical spine injury. So it has 3 steps. Step 1 is followed, then after that step 2, and after that step 3. So first of all we will identify whether the patient is a high risk factor or not. What are the high risk factors? There are 3 high risk factors. One is age more than 65 years, another is a dangerous mechanism of injury, another is paresthesia in the extremities. So we should be able to talk to the patient, we should be able to examine the patient, we should be able to take the history. That's why patient should be alert. So what is the dangerous mechanism? If there is a fall from more than 3 feet height or more than 5 stairs, there is an axial load to the head, is a high speed motor vehicular accidents, patient has a rollover or ejection from the bike, there is a bicycle collision, and motorized recreational vehicles injury. So these are the dangerous mechanisms, and these 3 factors are the high risk factors. If the patient is more than 65 years, patient is otherwise stable, still you go for the imaging. So we look high risk factor to decide whether you want to go for imaging or not. So yes, if the patient age is more than 65 years, that is a high risk factor, you should always go for imaging. If there is a dangerous mechanism, everything is okay, patient is neurologically stable, everything is normal, go for imaging. If there is a paresthesias in the extremities, go for imaging. And the imaging modality of choice is CT, cervical spine. So if you clear the patient from step 2, then you go to step 3. Step 3 is a low risk factor. It is a simple motovascular end-to-end accident. Patient is sitting in the emergency department, and patient is ambulatory, and patient did not have pain immediately after trauma. It is a delayed pain, and there is no midline tenderness on clinical examination. If all these factors are there, then you go for the ROM assessment. You tell the patient to move the neck. If patient is able to move the neck 45 degree left right rotation, then you can clear the patient of the cervical spine injury. That means patient is normal and do not need any other further examination or further tests for the cervical spine. Otherwise, if you find that patient any of these factors, that patient is not able to move the neck, then definitely we will go for imaging, and the imaging of choice is CT scan. So we have already talked about this. Canadian system is better than the NEXUS. So because its sensitivity is high, its radiography rate is lower compared to the NEXUS, and evidence level is class 1, and it is preferred. So CCR is preferred than NEXUS. Now the imaging modality, we have X-ray, CT and MRI. So clinically we always prefer CT because it is faster, it detects the bone. Maybe it may not be able to detect the ligament and the cord injury, but speed is very fast. This is what we need in a trauma patient. So the primary modality is always and always CT scan. Now why CT is first line? Because even in the high risk, if CT is available, then X-ray will not be able to show us the much information. CT will almost always show all the information needed for the management. So there are multiple articles related to this. So Van Guri et al., they suggest that CT is 100% sensitive for bone and ligament injuries. CT alone sufficient to rule out cervical spine injury. So but for the pediatric trauma, even for the pediatric trauma, MRI is not superior to CT. So CT is a modality of choice for cervical spine trauma. There another article by Khanna et al. They also said that if the GCS is less than 13 in a obtended patient, CT is normal, there is no neurological deficit, then MRI will not going to change the management. So again CT become the investigation of choice. So let's grade the neck pain. So how will you grade the neck pain? Grade 1, 2, 3, 4. So grade 1 is only pain, mild pain, moderate pain, patient is complaining of only pain. And grade 4 is after the imaging there is a structural pathology. Grade 3 is neurological deficit, and grade 2 is pain plus any activity limitation. So neurology is normal, but there is an activity limitation because of the pain or because of some other factors. So that becomes grade 2. If activity is limited, then it is grade 2. So this is how we grade the pain. So let's look at the summary of this article. We have a patient in front of us in the emergency, and if the patient is awake, asymptomatic, we have done CCR. Patient is having no high risk factor, patient is able to rotate the neck on both the sides, then we will not go for any imaging, we will clear the patient. If patient is awake and symptomatic, then we will go for CT. And if patient is obtended, then also we will definitely go for CT. If CT is normal, then we can wait for some time, and if needed we can go for MRI after 1 or 2 days. So this is how we go for the imaging in the cervical spine. So this was about today's video. Thank you guys, thank you very much. For more such videos, please like, share and subscribe to our channel. Thank you.